We are waiting for one more member and we'll get started. Hit the sub, I think. I was just leaving you a stern message. Okay, where's my agenda now? Thank you, ma'am. No, gonna steal this one. You grab one off that one. Okay, we're ready to get started now. Great, we got some extras. Good. Thank you. Our next governor just arrived. Thank you. Representative Blackman, would you come forward and present your bill?
Mr. Chairman, could you say that for the people in the back? They didn't hear you.
Just sit down and listen. Thank
Those of
you.
you who didn't hear him.
Yeah. Go ahead. Which one is this?
Hold on.
Try it now.
That do it?
Yeah.
Thank you, Mr. Chairman and members of the committee. I don't believe I've had the privilege of appearing before any health committee. So it's my honor to be here before you today to present House Bill 414. Try to be brief and answer questions, but this bill would establish the Veterans Mental Health Services Program up under the Department of Behavioral Health and Developmental Disabilities to distribute grant funds to organizations that come to our state and establish a center that would benefit our military service members, veterans, and their families, strictly as it relates to behavioral health and addictive disease. So that is what essentially the bill does. I think it's consistent with our commitment to mental health and to our veterans and our military families, and would certainly welcome any questions. I do want to thank the co-sponsors of the bill, Representatives Al Williams and Mary Margaret Oliver and Chairman Hatchett, for helping move this bill along and get it going. So.
Thank you. So you're speaking to substitute LC 540216S.
Yes, sir. We did need to clarify some language
Right.
so that we captured the behavioral health and addictive disease properly. Yes, sir.
Right. Thank you. Any questions of the committee? Hearing none. Do I hear a motion? We don't have anybody. Do I hear a motion? Sir. Any seconds?
Second.
All those in favor say aye. All those opposed? Congratulations. You got your bill.
Well, thank you, Mr. Chairman.
Good job.
Members of the committee,
Good.
I'm grateful.
Good testimony. Riveting.
Painless almost, right?
Well, you're not out of the room yet. Okay. I keep losing the agenda. There. Okay. Yes. They're all here for you. All right. How about Deborah Silcox? Representative Silcox. Yeah, 416.
Thank you, Mr. Chairman and members of the committee. I am delighted this afternoon to bring to you House Bill 416. And if you've got that in your folders, before we get started, I do want to introduce some special guests we have with us today. We have Sharon Scherer, who is an independent pharmacy owner, and we have her pharmacy technician, Heather McLeod, who was actually last year's the Georgia Pharmacy Association's Tech of the Year. So I appreciate them coming, and they're going to share a little bit with us after I walk through the bill. Looking at the bill itself, if you go through the pages of that, you start off the bill, and the first, really the top of the second page is really starts the meat of the bill. But what we're talking about is, of course, during COVID, we had a federal emergency declared. And during the federal emergency, we found the need to designate people as technicians, pharmacy technicians, to give COVID shots to cover the federal emergency. Since the federal emergency is expiring, that is the reason why we're bringing this bill today, to try to put some borders around a pharmacy technician, and to define that term and to give some conditions under which they can continue to give shots in our pharmacies. So again, at the top of page 2, of course, it talks about that of course a qualified pharmacy technician can administer vaccines under a supervising pharmacist. The pharmacist has to be readily available at all times. The vaccine, I think, very importantly, vaccines can only be given to adults 18 years or older. No children can receive vaccines from a qualified pharmacy technician. And of course, this has to be a vaccine authorized by the FDA and the CDC. In order to become a qualified pharmacy technician, going down to line 34, you have to have completed a training course accredited by the Accreditation Council for Pharmacy Education or a similar health authority. You have to hold a current certificate in basic cardiac life support, which I think is critical for giving vaccines because sometimes people do have cardiac reactions to vaccines. And of course, again, they're supervised by the pharmacist at all times. And they have to have completed a minimum of 2 hours of training of immunization related to continuing pharmacy education, again, approved by the Accreditation Council for Pharmacy Education. The supervising pharmacist, going on to page 3, has to keep up with all the reporting requirements established by the pharmacy board. They have to make documented reasonable efforts to obtain the name of the patient's primary care provider. And I think really importantly, they also have to report adverse events if they have a reaction to a vaccine or an event occurs in the pharmacy with a patient. They have to also check the Georgia Registry of Immunization Transactions and Services that tracks vaccines statewide, and they have to enter the patient's vaccine in the registry. In addition to that, they have to comply with applicable requirements set forth in the CDC guidelines. And of course, nothing in this code is going to require any pharmacist to authorize a pharmacy technician to administer vaccines or to require them to do so. And of course, the technicians cannot order vaccines. That would only be done by the pharmacist. This bill actually represents over 2 years of work, kind of coming together of private enterprise and the legislature and other groups that have been interested. And I will turn this over to Ms. Scherer, if you want to share some thoughts.
Good afternoon, Mr. Chairman and committee members. My name is Sharon Scherer, and I own Pools Pharmacy in Marietta, Georgia. I've been a pharmacist for a long time, but I've been an independent owner, and I've seen a lot of changes in pharmacy. I know some of you sitting on this committee have worked with pharmacy over the years and seen changes, and I'd like to remind you of when a member of the Composite Medical Board figured out that pharmacists administering under protocol for immunizations for flu vaccines was not legal. It had been misinterpreted. So we had a year where pharmacists could not administer flu vaccines. Then Governor Sonny Perdue asked the Georgia Pharmacy Association and the Medical Association of Georgia to get together quickly and pen a bill that could be passed quickly, because since pharmacies had pharmacists administering flu vaccines for 10 years, it had very much changed the landscape for providing immunization services. And we were really kind of in a public health emergency because flu vaccines have to be ordered early. So the doctor's office didn't have enough because they were depending on pharmacies to administer flu vaccines, and the public health department didn't have enough flu vaccines. But my point in saying this story is the way that was handled. We changed the medical landscape with pharmacists administering influenza vaccines, and it worked very well, and we had changed our workflow, and our community health and medical services depended on that too. So if you fast forward now, we've got a similar situation. We've had COVID for 2 years where our pharmacy technicians have been able to appropriately trained and qualified, have been able to administer COVID vaccines and flu vaccines, and it's very much changed our workflow in the community pharmacy. It has changed the ability for us to provide services. When COVID vaccines were approved, we weren't able to get them at first, but within 2 months, we were able to get them through the public health department, and at that time, the PrEP Act allowed technicians to become trained. We immediately sent Heather, our technician, here to be trained, which was one of the best decisions we made because we gave thousands upon thousands of vaccines. We gave them off-site. We went to nursing homes. We went to assisted living. We went a lot of different places, and Heather was able to assist our pharmacists throughout the whole process. And now pharmacies are so much as one place shop for immunizations, pharmacists that is providing other services like medication therapy management, counseling, chronic care management, point of care testing, now has a lot of help with the pharmacy technician. We oversee our pharmacy technician, but she does help us with the process and has done an amazing job. And so we would like to see this practice continue. It has very much become, I guess, a way of doing things in our workflow with the pharmacy, the way that pharmacy is administering vaccines. And we know from what the CDC is telling us that we probably will be giving flu and COVID from here on out. So we would like for you to consider supporting this bill. And as far as education is concerned, I think our Board of Pharmacy has been very astute in keeping our technicians requiring education. As a practitioner, I'm very, very comfortable with that. So I don't know if anybody has any questions, but I'd like to turn it over now.
And Heather, if you would share some of your experience as Tech of the Year.
I'm Heather McLeod. I've been a technician since 2013 and a certified technician since 2017. As soon as I heard that GPH was offering classes to be certified in vaccine, I signed up for the very first one. I later went on to also get certified by the PTCB, the Pharmacy Tech Certification Board. I got a certification from them as well. I was really excited to be part of the solution and to help my community. I was also excited to be part of the team in the pharmacy giving the shots. As I started administering the vaccines, I worked with the pharmacists and they coached me until we were both comfortable with me giving the vaccines. Since 2021, I've given several thousand vaccines. I'm really afraid that once this PrEP Act is over, all that training and experience is going to be, for naught. So please consider this bill.
Okay. Thank you very much. Representative Mitchell.
Thank you, Mr. Chair. I happen to personally know the good work that Chair Cooper and now Chair Silcox was put into this bill. This is, in fact, good government, and I'm prepared to make a motion of due pass at this time.
Okay, we have one other question. Two other questions. Representative Kelly, you 6?
7.
Okay.
Chairman, I think Representative Schofield's 6.
Okay. Let's let Lee go first.
Okay, thank you. Thank you, Mr. Chair, and thank you, Representative Silcox, for all the work you've done on this. I really do appreciate all the work that pharmacies have done, and I really think that this is especially important because as I've been tracking a lot of the pharmacy deserts and targeted zip codes, your role becomes very crucial. So, again, I want to just thank you on behalf of the constituents that have that need you. And say, if Representative Mitchell didn't say, I would like to make a motion to do pass at the appropriate time.
Thank you, Representative Schofield.
Thank you. Representative Kelly.
Thank you, Mr. Chairman. I'm generally supportive of the measure as well. I'm just trying to just understand everything. During the COVID state of emergency, were the techs able to do vaccines for children as well, or children and adults? Or
The PrEP Act changed several times, and at one time, I think it still says that they could give children's vaccines. We did not do that. We just focused on mainly the adult. The pharmacist did the adult vaccines. The technician could only do flu and COVID in our practice. But yes, at some point in time there was. We just did not practice that way.
And just out of curiosity, and again, I'm going to support the bill, but why did we decide to make this policy shift to just adult vaccinations now?
Go ahead. You go ahead.
Adult vaccinations, I think that that has pretty much been very accepted across the country, that technicians could work with adults and give vaccinations, could give consent. And we've worked with children, we can immunize anybody, I mean, any child or anything, as long as we have a prescription. But this is talking about working without prescriptions from a physician.
Got it. And thank you. I was trying to just get clarity. Thank y'all.
It's-
It's a good bill. I look forward to supporting it.
Thank you, thank you.
Okay. Well, I tell you what, since you were up first, what number are you, Billy? 12? Go ahead and make your motion.
Yeah, Mr. Chair, I gladly offer this motion to do pass.
Second. All those in favor say aye.
Aye.
All those opposed? Congratulations.
Thank you very much. I
Representative
appreciate it.
Silcox, you got your bill. Thank you. Okay, up next, Representative Newton, 343. I don't care. You do it work from there or from the mic, a podium mic.
Well, thank you, Mr. Chairman.
Yeah.
Members of the committee. I enjoyed it today when on the House floor we made an effort to just find a small group of Georgia patients and citizens who have to get contact lens renewals. We came up with a bipartisan way to give them a little bit of break on when it comes to affordability, access, and convenience, which is something we're looking for all the time in healthcare. Well, that was a small group of patients who wear contact lenses that were between 21 and 50. So
Did we pass that one?
we did
already?
pass that 100%. What I want to bring today in House Bill 343, by the way, it's LC number 339346. What I want to bring is a measure that we passed overwhelmingly this past year, last year, and it ended up dying out of time in the Senate, which is a way for patients across Georgia, family members, individuals who have a pharmacy need to take care of their condition. Some medical needs are surgical, some are medical. Some of them can be solved by medications. In particular, there's some newer medications that can be life-saving or even life-changing or even life-saving. So that's what we want to talk about today, which deals with pharmacy benefit managers. To begin with, you got to know a little bit about how medical bills are processed. Many of you are young enough that you probably haven't seen a lot of explanation of benefits, but those of us who have, or people who have family members who have, there's often, when a surgical procedure is done, there is a list price. And then the good news is nobody has to pay that, because you look down and you see that your insurance company, hopefully if you have one, has negotiated a much lower contract price, sometimes 80% lower. So that's great news, because you have to either pay a deductible or 20% of that amount. So you're glad if the bill said $10,000, but the negotiated amount is $1,900, you're pretty excited that you're only paying 20% of $1,900. So that's the way it is with hospitalization. That's the way it is with surgical fees. Same-day surgery centers, doctors' offices have a list price. Maybe even dentist offices have this too. So there's a price, but that very few people pay because of the contractual ability of insurers to negotiate rates way below what the list price is. Well, there's one area of healthcare that this doesn't apply, and that's when you or your family member needs an expensive medication to take care of their either life-altering or life-saving medication. There is indeed a list price, and there is indeed a contractual adjustment, often called a rebate. So there is an agreement with the people who sell it, and then a rebate, a contractual amount that's either paid back to the PBM, and there's a lower amount. Unfortunately, when it comes to pharmacy benefits, the insurance company tells the pharmacy where you're picking the medication up that this is the list price. So if you can just say a 50% rebate, which on a brand name medicine that's life-altering or life-changing might be 50%. So it's $1,000 a month medicine. You may have to pay, maybe there's a $500 rebate. Unfortunately, you pay 20% if you're in that category. You pay 20% of $1,000, not 20% of $500. So 20% of $500 is still expensive, but for a life-changing or life-saving medication, many of us think it would be well worth it for us or our family member. So that's the simple background between what a PBM does and why pharmacy benefits have been carved out kind of differently than all other medical and surgical treatments. That's what HB 343 seeks to make a step in the right direction. Doesn't say they have to give all that rebate to the patient. Doesn't even say they have to give a lot of that rebate to the patient. It simply says that a pharmacy benefit manager, when they send the information to your local pharmacy or your independent pharmacy or wherever it is for how much to charge you, instead of it being $1,000, they have to give you credit for at least 80% of the rebate amount. So it does recognize that PBMs and insurers do a valuable job in negotiating these discounts. So it allows them to keep up to 20% of that rebate amount like they get it now. And so that allows the patient to pay, let's just say 20% of $600 in the case that I imagine. So over time, you can imagine that makes a big difference, especially if a family member has an illness or a condition that needs one of these medications and that they and their doctor think this is the best alternative for their health care. So that's what we're trying to do in House Bill 343. It does have some particular exemptions because we recognize this is a fluid environment, both in healthcare but also in the political world, the realities. This bill today that we see today, unlike last year's bill, it does omit a group of plans that are self-funded. They call them ERISA, Employee Retirement Income Security Act, but they are only federally regulated. They're not really regulated by the commissioner. And if you'll see in the current bill, it says on line 58 through 60 or through 61 that this bill only applies to ones overseen by the commissioner. That's understood to be in this bill, the code section, that's the commissioner with the Department of Insurance. So that does exclude these large employer plans, large self-funded plans. And let me tell you why I think that's actually not a bug, but a feature that we're excluding 62% of Georgians. Many of us are on state health benefit. All our teachers are often on state health benefit plan, over 600,000 covered lives. Large employers like that have the bandwidth to go to an insurer and a PBM and say, wait, we want transparency. And they can demand it when you're that big and you're that big, writing that big of a check every month or every year to an insurer. You can demand transparency. It is some confidential information, so they'd use a confidential third-party audit to look at all the prices of the medicines that were list prices and look at all the rebates and add them all up and let the payer, SHBP in this case, let them know what the total of that was. And then SHBP will take that and lower everybody's premiums evenly. Now, if you happen to be one of the unfortunate ones who needs an expensive medicine to stay alive or to thrive, you might say it's not quite fair, but at least everyone's getting the benefit because there's transparency through an audited third-party auditor who keeps confidential the price of the rebates but also shares the total of the rebates with the insurer. Large plans are able to do that. Coca-Cola's, UPS, Delta, they're large enough to demand that in the same way SHBP can demand it. Who can't demand it are the ones that are overseen by our state insurance commissioner, the smaller plans, the small group plans that are fairly small. We've chosen in this bill to do two things. Instead of like last year, what was passed nearly unanimously was give a full credit for the rebate. We've lowered that to 80% to recognize the value of PBMs and insurers in contracting. We've also excluded these large ERISA or these large self-funded plans that come under federal regulation. That's up to Washington to decide how to make sure fairness. And believe me, there are some efforts at the national level to deal with that part of it. What we can do for Georgia families and Georgia patients is we can make a difference in their pharmacy price right now for the plans that are overseen by the Department of Insurance here in Georgia. We won't disrupt any of the large employer plans. Some may say and come after me and say, well, these are going to raise premiums. Well, that is the case. As I mentioned with state health benefits, if you didn't apply those PBM savings, those rebates, those contractual adjustments, the difference between what they told you the medicine cost and what it actually costs your PBM, those you can demand that those be included to lower premiums. What we don't know with these state-regulated smaller plans, there's no transparency. There's no way for us to arrange a third-party audit to make sure that all that rebate money is going to reduce premiums. So people are going to say, well, it's going to raise premiums. There's the old phrase, trust but verify. We'd love to have their support behind a true transparency model to just go in and tell the patient, just like you do on a knee replacement surgery at a surgery center. It's, whatever, $17,000, but the contractual adjustment that my Anthem plan gets is $5,000 is the price. I'd be in favor of that, but I can tell you I don't think they're able to make that promise, and because of that, I think we need to pass pass along, if we will, HB 343 so that Georgia patients can pay a fair amount for their medications when those are life-saving and life-changing. So glad to answer any questions.
Representative Patty Benton.
Thank you, Mr. Chairman, and thank you,
Bentley.
Mr. Chairman, for your work on House Bill 343. But to just, if you can, just explain to me exactly, without this bill, what does that mean for the patients in the state of Georgia? If we don't, this bill never exists, what would that mean for Georgians going forward?
Right now, patients are being told, and their copay is being calculated on a price that's not accurate. They're being told the medicine is X amount. But with many medicines, especially brand names, the newer medicines that are really valuable at changing your lives, a lot of times we don't know what the real price is and they won't divulge it. This bill requires them to it gives them a range up to 80, as much as 80%, 80% or more. They can give 100% of the rebate credit back to the patient, not a check to the patient, but just, once again, in the $1,000 versus a $500 true price. They can make it based on $500, they can make it based on $600. They're going to give 80% of the rebate in calculation back to the patient. So the patient's only going to pay 20% of $500 or $600, not $1,000. So without this bill, right now, the patient's just being told that medicine costs $1,000, you owe $200. And if we don't pass this bill, that'll keep happening with pharmacy benefits only, not the other ones.
All medications or just certain types of medications?
No, generic medications generally do not have much or any of a rebate. Sometimes there is what was called steering to one medicine or another because the PBM has negotiated a better contract with, if there's two fairly equivalent medicines, they might have negotiated a much better rebate from this one. Even though both of them may say $1,000, this one might have a rebate of $200, this one might have a $500 rebate. They'll steer you into that other medicine and tell you it costs $1,000. There's some of that goes on, but this isn't all medicines, but there's a subset of medicines where about 40% of the value is tied up in rebates.
Okay, thank you.
Yeah, I just want to, yes, Mr. Chairman, thank you, Mr. Chairman. What about this notion of plan inflexibility? Can't the plans elect to do this themselves right now?
Well, it would, to really tell whether the premiums, they do sort of with the large ERISA plans that I mentioned. They do provide an avenue for transparency for the payer if you're a really large employer. What they don't allow is the Department of Insurance to see this information. They don't allow the patient to see the information. They don't allow the doctor or the pharmacist to see this difference in the list price and the contracted price or the post-rebate price. Nobody allows that to be seen, so there's no way to verify that they are indeed lowering the premiums as much as they're now going to say they're going to have to raise them. There's no way to verify that. They could offer transparency today, it's just never happened. I mean, you can ask them directly if they'll offer the transparency, full transparency on contractual adjustments, the way hospitals have to do under federal law now. They have to tell what their rate with Blue Cross or United is.
You know, Mr. Chairman, as an aside, I noticed that there are more Democrats here than there are Republicans. I may have to move for expansion of Medicaid at the proper time.
Representative Bentley.
So, just another question,
Yes, ma'am.
Mr. Chairman, and this is a serious question. I'm just trying to, I'm asking just so I can better understand. I have my own way of comprehending things, and you know the business that I'm in, so you
It's
know where I'm
worked
about to
well.
go with this. In the funeral industry, we are required to keep a general price list of all of our inventory, and the family, just like a patient, want to know what that price is. I have to have that general price list available so they can see what my prices are. And what you're telling me, I'm kind of associating what you're trying to do, the same thing that I'm required to do now in the funeral industry. Because like what I'm thinking is like this is not happening now. That they just give you a price and you don't have, as a patient, we don't have a way of seeing or knowing if that's really the accurate price that they're charging us. Am I comprehending that correctly?
If the casket manufacturer gave you a list price of, I don't know, $2,000 for a casket, and you told the patient it was $2,000, and then you never told the patient that you were getting $800 back from the casket manufacturer per casket, that would be the problem. I think you ought to tell the
family
that $1,200 is the
Not the
price,
deceased.
because that's your price. Don't. It's a little different with insurance because of the fact that patients have a portion of the year that's under a deductible, good portion of the year that's under a 20%. So it's not that they're paying the whole price, they're paying 20% of an amount. This is trying to get them to pay 20% of the true price. I don't know if some of those, that inventory has a manufacturer's suggested price that you don't necessarily do because you're a great businesswoman. You may have a lower price than what the manufacturer says it is. You charge your families based on what the true price is. And that's another way to look at this. Is this the true cost after all contractual adjustments or rebates? What's the true cost that your insurance is paying or your PBM is paying?
Gotcha. Okay, that helps me.
Thank you.
Thank you.
Representative Schofield.
Thank you, Mr. Chair. Just a quick question. I'm curious. What impact would this bill have on, let's just say, on 340B, like a hospital like Grady?
This does not touch 340B program. The 340B is a unique program, and it's directly with the manufacturers under federal guidelines. This does not address 340B programs.
Okay.
Representative Kelly.
Thank you, Mr. Chairman. Representative Newton, isn't it true we had this legislation last year? Is that correct?
We did, yes.
What happened?
Well, there was, as I mentioned, we've changed this bill a little bit from last year. We have exempted the large employers, but with some due process, if you will. We've looked at the fact that they are big enough to negotiate their own transparency. Smaller individual plans or small group plans or small company plans don't have the bandwidth of a 600,000 covered life SHPP or however many Delta and other large companies might do. So we did take that out purposely to make sure this did not disrupt a system that may be working okay for the patients in a way that they're able to demand that somebody, an auditor, gets to see behind the curtain, if you will, and guarantee them and alert them that they're getting an appropriate deal and an appropriate premium reduction. We don't have any of that transparency on the smaller plans. And so that's what this bill seeks to give a level of parity to the ones that are in a smaller company, like my company or others, and you're buying a corporate group policy or people who are on an individual plan. They'll be able to get the benefit as well of the, in this case, the reduction of the cost of medications.
How strongly did it pass the House last year?
It was nearly unanimous, I believe, 170 to 1 or 2, something like that.
Thank you.
Seeing no more questions, Jesse Wethington.
Good afternoon. Thank you, Mr. Chairman, members of the committee. My name is Jesse Wethington. I'm the president of the Georgia Association of Health Plans. We're the state's commercial trade group representing the health insurance industry. It wouldn't be a session of the General Assembly if we were not up here talking about pharmaceutical rebates. And so this is no different. Appreciate Chairman Newton. I've had a couple of conversations with him with this bill. Generally, our association's issue with this is that we feel the bill is not needed because both of these options presently exist in the market today. So a plan sponsor can go ahead and purchase a POS rebate plan. Of the 8 member companies that we have in our association, 6 would be affected by this legislation. The other 2 only sell on the exchange market. One of whom would not be affected because they have a closed medical model. You may have heard of them. Their tagline is it's different. So their pharmacy claims are handled a little bit different. Of the remaining 4, 3 offer some version of a point-of-sale rebate plan presently. When CVS Caremark, which is a large PBM, was also affiliated with the Aetna health insurance carrier, offered a point-of-sale rebate plan on their Medicare Advantage product in 2019 or 2020, I believe it was. Only 25,000 people nationally ended up enrolling for that plan. And so what we typically see is that for both plan offerings, the customer, be it the plan sponsor or the individual, typically chooses the more traditional option where the rebate is kind of built in aggregate to the plan and discounted against everybody in the pool's premium. So for the example, say your aggregate premiums for your group were supposed to be $1 million. You got a $100,000 rebate, then everybody's premiums would be reduced by that rebate to be $900,000, and everybody in the pool would have the benefit of those savings. That essentially is our issue with this. We think that the market's provided a solution for this now, and we would urge you not to choose consumers to purchase a product that they can today that they generally have not. The uptake on these is generally low, either in the low teens or single digits in terms of the specific splits of our plan. You'd ask for a specific breakdown on that. I'm still trying to get that. The other thing we would request, should this bill move forward, I had spoken with the chairman about this, was we would request that the sort of generic ERISA exemption language that's present throughout the code, and I know the chairman dealt with that issue in the last 2 days on an issue, so you're very familiar with it. We would like that ERISA language put into this specifically to make it absolutely clear.
Okay, thank you. Next up to speak is Dorothy Glasser.
Thank you very much, Mr. Chairman, and thank you, committee. I'm here again, as I was last time, to talk about House Bill 343. I'm Dorothy Leone Glasser. I'm the Executive Director of the Advocates for Responsible Care. We are a nonprofit advocacy committee. We are not lobbyists. And we also are working with a 42-partner organization, the RX and Reach Georgia Coalition. We work hard to expand affordable access to prescription drugs and treatments that patients need, especially chronically ill patients. I am a nurse specialist, and I have been working my entire life to give voice to the patients. We receive calls daily from critically ill patients who need the benefits of rebate pass-through legislation. We urgently ask for your support of HB 343 because we have to try to get other patient access bills just like this one through this wonderful committee. We've been here many times trying to get provisions of 343 through other bills, like our step therapy bill that we did in 2019. This time, we have another opportunity with 343 to be able to do this for the patient's sake. I'd like the committee to please remember that most of the medications we're talking about that will be affected by the rebates are not generic drugs. There is no substitute, no equivalent for these drugs. These drugs are for patients who are seriously ill and chronically ill, and the rebate will make all the difference for them if they could get this passed through directly at the point of sale, which is at the pharmacy counter. Drug manufacturers willingly give rebates and discounts. Some of us as advocates have worked with them for many years to try to develop these rebates so that the financial burden of these expensive cutting-edge drugs would be taken off the backs of the patients. The amount the patient pays for medicine, either through their deductible or through their coinsurance, is often based on the full price of the drug, of the medicine, rather than the deeply discounted amount that the insurer actually negotiates for. Rebates were created by drug manufacturers to help the patients. Instead of using rebate savings to reduce the patient's out-of-pocket costs, health plans keep the savings as profit. Everyone in the drug train is sharing and getting profits, but the patient is left with paying a high cost out-of-pocket for life-saving drugs and not receiving the savings that they would get with this rebate. HB 343 directs the pass-through of 80% of the rebates to the patient at the pharmacy counter. So their payments are based on the true net cost of the drug and not the list price, which is what is happening right now. This could save Georgians, according to a Macmillan report, almost $1,000 a year, those of us who participate in the rebates. I am also a survivor of cancer and of lupus, so this particular bill is very personal to me, and I talk to patients every day who need these medications and they can't afford them, even with their insurance. The other thing that 343 does is that it provides a cost transparency that we have never had. It requires an annual report by the insurers on the amount of rebate passed directly to the patient. This report will be submitted to the Georgia House and Senate Health Committees. The health of patients should always come first, and our access policies should always have the patient in mind for their medications and treatments. Without rebate savings, patients pay a high cost for prescription drugs. Patients deserve these rebates. They were created for them, and as they receive their drugs, They will help keep them active and working and reducing their disease flares and improving their quality of life, which always results in better health outcomes and in reducing the health system costs. I urge you today to please pass HB 343, and I thank you for all your service to Georgians and your attention to future health policies that improve Georgians' lives.
Thank you, Dorothy. You have a question. Representative Bentley.
Thank you, Mr. Chairman. It's more of a comment. I thank you for your presentation. You said just what I wanted to hear, patient first. And from my ordeal with my husband back in 21, and I want to make sure everybody in this room know this, if you legislation that's going to put patients first, you can expect support from Patty Bentley. If it does not put patients first, then don't even, my phone is dead anyway, so don't even text me. But thank you.
Thank you.
Thank you.
Thank you very much.
Representative Mitchell. Excuse me, one more question. Representative Mitchell.
You know, the question comes is what will happen as a result of the lost revenue. It has been my experience is that the providers are not just going to eat lost revenue. I think this is an opportunity for it to become more expensive. What do you say to that?
We, as advocates, we have never seen that any bills like this that would allow the patient to afford their medication leads to more expense in the insurance arena. I think that's an argument that is old. It's been well played. But for us, what's really important is to directly see that patients are allowed to get their life-saving drugs when they need them without creating a further burden. Any patient who doesn't get the drug that they need when it's not a generic drug like this, that there's no other option, you're going to see them having a decline in their health, which means that there'll be emergency room visits, more doctor visits. The end result is a greater burden on our healthcare system. The manufacturers definitely intended these rebates to go directly to patients. Last session, with the great leadership of Dr. Mark Newton, we had 100% of the rebate going to the patient. We negotiated, and now it's down to 80%. I don't want to have to come back here next year with the argument that, well, now we're asking you to just give the patient 50% of their rebate. It's important that patients get this because it was intended to ease their financial burden. Any other questions?
Yeah, Representative Sharper.
Thank you, Chairman. I think, with the information that we've seen and also what we've seen in the past, this particular bill, like I say, is in the favor of the citizen, and that's very, very important. So if it's for any good, I endorse this particular legislation, and I think it's a win-win. And I see that you guys took the time to say that we'll take less. So I think it's a move in the right direction. So I'm for it, and I support it.
Thank you, sir.
Representative Newton.
Thank you. Thank you for being here, and thank you for your passion on this. I think what I heard you saying, too, is that if patients can get these needed medications and they're not cutting the pills in half and skipping a week because they ran out of, they don't have enough money to pay the higher price, that overall that could lower health care expenses because of not having the ER visits, the hospitalizations that come from trying to spread out your medications or skipping them or not filling them for a month. Is that what I understand you?
Absolutely true. We see this every day. The Advocates for Responsible Care, we hear these stories every day. Well, I couldn't take the full dose. Or in many cases, for some of these drugs, they're infusion drugs, they're biologics. So if the patient can't have this, there's no chance of them being able to control their illness. The disease is not manageable. We have the advantage, and in Georgia, being an innovative hub for medicine here and for biotechnology, to be able to give patients the drugs that they finally need that can bring them to be productive citizens of Georgia.
Good, thank you. Thank you very much. Next speaker, Heather Madden? No. Oh, I'm sorry, Michael Power. Michael Power, I'm on the wrong one. PCMA.
All right. Good afternoon, Mr. Chairman, members of the committee. Is this on? Okay, great. My name is Michael Power. I'm with the Pharmaceutical Care Management Association. We are the national trade group that does represent the PBMs, which are much of sort of the discussion here today on House Bill 343. I would like to highlight quickly that across the country, PBMs cover about 277 million Americans, with nearly 8.9 million Georgians receiving their prescription drug benefit through a PBM. Our organization represents about 20 of the PBMs in the country, but there are 70 that operate today nationally. So today we are here, though, in opposition to House Bill 343. While we do agree with the sponsor that lowering the cost of prescription drugs for patients is critical, we feel that House Bill 343 misses that mark. The general issue with that is that it seeks to mandate terms on private contracts. You heard today before from Jesse Wethington with health plans that plan sponsors have really three options on how they use those rebates. And they do get that information. They get that in a quarterly report or an annual report, depending on how they design that plan. But they can use those rebates to lower the cost at the counter for patients using those drugs. They can lower the premiums paid for all lives in their benefit. So all the lives that plan covers, whether it's 1 or 10,000, they can use those rebates at the end of the year to lower premiums for all of those lives in the plan. The last thing that they can do is we have to remember that health insurance is largely provided by employers in this country, and they pay more than 80% of the program that they're providing voluntarily to their beneficiaries. So they could use that rebate if they so chose to lower their out-of-pocket spend on overall healthcare spending, making it easier for them to provide healthcare the next year and the year after that. Well, the chairman does point out that the way the bill is written right now, it exempts ERISA insured plans. It does still leave the weight of this legislation on small employers in the state, 100 to 50 employees or less. They would still have to bear the burden of the cost of this legislation. So while those ERISA plans are exempted, leaving that discretion up to the commissioner, not this legislature, they are exempted from this bill. We would agree with Mr. Wethington that language that is similar, exempting ERISA plans, that's found throughout the entire insurance code should be included in this legislation as well. One thing I'd like to highlight for some of the previous testimony, it is accurate that rebates largely exist on brand drugs. Generics have little to no rebates. PBMs prefer generic drugs in our plans. However, there's such an incentive sometimes to use a brand drug over a rebate that a plan sponsor will choose that in order to get that discount back from the drug manufacturer. And so while it was stated earlier that the rebates were established to help the patients, the way that these plans work, there's formulary design. And drug manufacturers are willing to give rebates based on volume that accrue in the rear if their drugs are placed on formularies and then used at a certain level by patients across this country. So that's one of the issues. The second thing that I would like to highlight that is being talked about at the national level and sort of not here today is the abuse of drug manufacturers and patent thickets. There's been a lot of recent stories in the Wall Street Journal and other publications stating that drug manufacturers have been abusing patent law, extending the cost to consumers on prescription drugs. I think Humira was one of the drugs recently in the Wall Street Journal, and I think they found it was like $1.8 billion in increased cost to consumers by abuse of patent thickets. And so while I understand the intent of this legislation is to try to lower costs for consumers, I think we've sort of missed the mark here today. And for those reasons, we'd respectfully oppose House Bill 343.
Thank you. We've got someone up. Representative Mitchell.
You too believe that the patient is paramount first in how we deal with health care. Am I correct?
Absolutely. We view it's our role to help lower the cost of prescription drugs for consumers. We're the only one in the market.
Thank you.
Okay. Up next is, let me see, we got Heather Breeden.
Good afternoon, Mr. Chairman and committee members. My name is Heather Breeden. I represent the National Multiple Sclerosis Society. Standing with me today, I have a young man living with multiple sclerosis, Mr. Kayan Imami. He is applying to medical school in the near future, so he's here to learn a little bit about policy today, but he also lives with MS. I want to point out to you that MS is a neurological condition. It is the #1 cause of non-traumatic disability for young adults. The folks I represent will be meeting their deductibles for the rest of their lives. MS is a disease that you can live well with. However, it is very important for that patient population to have access to disease-modifying therapies. The average list price on an MS drug is $94,000 a year. There are only 3 generics. 40% of the MS population alters the use of their medication because they are concerned about the cost of living with MS, and they do not know if it's sustainable. They will cut medicines in half, or they will go off their drugs, which can cause new lesions. MS is a disease that causes lesions on someone's brain and spinal cord when their immune system attacks the sheath on their nerves. It's serious, but with the right drugs, people can live well with MS. This bill matters to MS patients in Georgia. 80% of the rebates during the deductible period being passed back to patients is a game changer for folks who are living with expensive medical conditions. So I ask that you pass a strong version of this bill out of committee. For years, the MS Society has been talking about PBM transparency. It is a system that is vertically and horizontally integrated. The insurers often own the PBMs, and the PBMs, in some cases, own the insurers. We need transparency with the math associated with prescription drugs. Thanks so much.
Thank you. Thank you. That ends our testimony. Do I hear a motion on this bill? Second?
Second.
We have before us an amendment you have on your desk that we will take up before voting on the measure. Would you like to introduce your amendment?
I will, and actually.
Which, excuse me, what number? Number 3. Okay, gotcha.
Thank you, Mr. Chairman. Yes, in an effort, as we have, to try to work with the industry as well to make sure we're being clear in our intent and our accomplishment, there's an amendment that reads as follows, and this would go at the very end after line 81 at the very end. It's an H section. This says, this code section shall not apply to self-funded employer-sponsored health insurance plans regulated under the Employee Retirement Income Security Act of 1974 as codified and amended at 29 U.S.C. Section 1001 et al. That was a kind of a belt and suspenders to the lines I mentioned earlier on 59 through 61 to just assure that, once again, those large companies that are able to negotiate and get transparency, that they are not the goal or the result of this bill, but all the smaller plans, as I said, 50 to 100, or individual plans that are governed by the insurance commissioner. So that's my amendment, sir.
Okay. Do I hear a motion on the amendment? All right, all those in favor of the amendment, say aye.
Aye.
Okay, back to the main bill. All those in favor of the main bill, say aye.
Aye.
All those opposed? No. Okay, the ayes have it. HB 343 is passed. Congratulations, Representative Newton. Okay, next bill, 441 by Representative Dempsey. Was that you that was in there? Yes. Yeah, I think I was. Thank you, Representative Dempsey. You may begin. Excuse me. We got a bill up. Go ahead.
Thank you so much, Mr. Chairman and members of the committee. So I bring to you today HB 441. What this bill will do is authorize and regulate the practice of teledentistry in Georgia by Georgia licensed oral health care team members via permits issued by the Georgia Board of Dentistry to ensure patient safety remains the priority, maintaining a continuous standard of care and sustaining the Georgia licensed dentist as the leader of the oral care health team. It addresses current general supervision of hygienists and expanded duty dental assistants in an effort to reach more Georgians and promote oral health and wellness. Everything in this bill builds on the foundation of HB 154, which passed and was signed in 2017, that allows hygienists to work outside of a private practice in safety net settings. This bill creates a network of dentists within our state that can work together to ensure patient safety. It allows for a more thorough and real-time consultation with dentists via their auxiliary personnel that gives Georgians better access to oral health care. You know, a lot of things changed, I think, during the pandemic. This conversation was going on pre-pandemic, though, particularly for the hygienist community, and that's when, in 2017, as you heard, the measure was passed. Many of you served on the health committee at that time, and we talked. We saw large amounts of pictures and huge discussion about the challenges in many of our safety net population that really needed access to real-time, real health through dentistry, and the impact that it has on a life if you are not working in the prevention mode. But with the pandemic as well, some of those things certainly have increased, and we found all kinds of ways to deliver different varieties of telemedicine. I think as Chairman Newton spoke just a little while ago, his bill passed today on contacts and how we could do that. That sounds like an impossibility. There are certain things that we can do that help the greater population, and we need to. The use of teledentistry can be appropriate and effective as a tool for consultation, education, and as a means of supervising qualified dental auxiliary personnel in the delivery of oral health care. It is the delivery of that care by qualified auxiliaries using secure technology under the general supervision of an authorizing Georgia licensed dentist to a patient physically located at a site in Georgia that is different from the site where the authorizing dentist is physically located. This bill addresses the general supervision of hygienists and expanded duty dental assistants in an effort to reach more Georgians and promote oral health and wellness. I'd like to ask that Risa Garcia Robertson give us some more information specific to it, and then we also have two dentists that are here.
Go ahead.
Members of the committee, thank you for having me. I'm Teresa Garcia Robertson, and I represent the Georgia Dental Association. Chairwoman Dempsey covered the bill very, very well, and if you have questions, I'm happy to take them, but she did a great job.
Any questions? Look like you're easy right now.
I like that.
Thank you. How about Dr. Peter Schatz?
Members of the committee, Mr. Chairman, I am Peter Schatz. I'm a practicing dentist in the state of Georgia for the past 30 some odd years and have extensive experience in this field, and would like to rise to speak in favor of this bill. Some of the aspects that have been up for discussion includes the distance requirement for the supervising doctor over these qualified auxiliary providers, and this is actually consistent with the regulations that the CMS does with the Department of Community Health here in Georgia. So that remains consistent with standing statute in our state. Also does not change or affect the Dental Practice Act by requiring those that are supervising patients within the state of Georgia be actually licensed or certificated within our state to provide such care. The other part of this bill is the need to develop a network for access to care, in that dentistry, unlike primary care or triage medicine, is a contact sport, pardon the expression. tactile diagnosis, visual diagnosis, which is not readily able to be done with all types of cameras, the touch and feel of a patient, the probe of a dental explorer into the patient's oral cavity can detect disease that a camera or a conversation cannot. In that it lets us provide care by a licensed dentist and have access to somebody if the scope of care of these patients is beyond what a dental hygienist or dental auxiliary can perform, then we have a direct known referral to that patient's supervising dentist. In-person dental examinations are quite different than digital examinations with remote access equipment, in that the resolution, quality, and the lack of touch by the diagnosing doctor is not present in these telemedicine, teledentistry type evaluations, which makes up a significant portion of the dental examination itself. With that, I'd like to open up for any questions.
You do have a question. Representative Bentley.
Yes, sir. Thank you. Thank you for being here.
Yes, ma'am.
And thank you, Chair Lady Dempsey, for your work on this bill. But I just want to make sure I'm clear on this 50-mile radius. Within 50 miles of where the teledentistry interaction will occur. Help me understand that. Does that mean that you, as a dentist, you don't have to be in the same room with the dental assistant?
Correct. We
Okay.
do not need to be co-located with the patient, but within a reasonable driving distance, which is similar to what medicine has for FQHCs and safety net settings, where the supervising doctor of medicine has to be within a certain geographic area for access of that doctor to the patient at the patient's locale, or conversely, ready access by that patient within a reasonable distance. So for me, for instance, in Cobb County, to supervise patients down in Thomasville at the southern border of southwest corner of Georgia, it would be unreasonable for me to say I can hop over there in a reasonable amount of time and help the patient. And conversely, these safety net patients may not be able to come to me for said care because of the distance.
Gotcha. All righty. Thank you.
Yep.
Representative Kelly.
Thank you, Mr. Chairman. And Doctor, thank you for being here with us today. I know it's hard to take time away from your practice and everything to be here, so thank you for being here. Help me just to understand in practice kind of some of the differences in terms of responsibilities inside your office between dental hygienist and dental assistants. Can you kind of speak to that just practically for me?
Yeah, dental hygienists are actually a licensed provider in the state of Georgia. They're licensed similar to physician's assistants in the medical world, operate their business under the supervision of a licensed dentist. Their scope of work includes screening evaluations, collection of data, cleaning of teeth with various procedures. Dental auxiliaries, the dental assistants themselves are more of the aid providers to either the dentist or the dental hygienist, prepping rooms, moving patients, initial data collection, and some limited procedures such as minor repairs of certain dental prostheses and such.
Thank you. Just
Yeah.
trying to understand. Thank you.
Mm-hmm.
Who's 18? Representative Newton.
Thank you for being here. I'm trying to understand just a little better the 50-mile target range. I'm just curious. I know at least with almost every other specialty in healthcare, we have large areas that 50-mile radius might not cover. Is there, and I know every dentist is not going to offer this, are there areas of Georgia, if you drew a 50-mile circle around every dentist, that we wouldn't have any gaps in potential coverage? Or
to borrow a phrase about healthcare deserts, there are dental deserts within the state of Georgia. There are certain counties, perhaps even, where there are none or very few dentists, and rural access to healthcare, including dentistry, is severely limiting. Having said that, there are also significant portions of the state of Georgia that are occupied by farmland and livestock that, with a low population density, that may not support the business of being a dentist or being able to provide that care. The distance requirement within this legislation, however, has not about creating access to care for patients that aren't within a reasonable distance, but that if we assume the responsibility of a patient, that they should be within a reasonable reach thereof.
okay, thank you.
Representative Sharper.
It's more of a question for, thank you, Chairman, for Representative Dempsey or somebody. When we're looking at line 12, regulations to provide for dental assistants to perform coronal polishing under the direct supervision, and then it goes on. Now, can the dental assistant do that now? Number 12.
I'll take that question.
Okay.
Yes, coronal polishing is the phrase, which is the visible part of the tooth in the mouth. A dental assistant can polish that versus a dental hygienist, for clarification on roles. They can actually apply instruments that can reshape or remove hard attached accretions on the teeth themselves and go below the gum line. This is up in the visible portion of the mouth. So
Okay.
it's a different thing. It's not a full-on prophylaxis or cleaning that you would get by a dental hygienist or dentist.
Okay.
All right. Thank you. How about Dr. Jamie Mitchell?
Thank you for your time.
Thank you.
Mr. Chairman and committee members, thank you for hearing us out. And I'd like to speak in favor of House Bill 441. Just a little about myself. I'm a general dentist in Monticello, Georgia. I don't know if y'all know much about Monticello, it's a small rural community, home to Tricia Yearwood. Thank you very much. But anyway, we are a rural community. We're small. I'm the only dentist in town. I do have an associate with me, and we do provide Medicaid. We feel like it's a vital part of our community to give back. There are a lot of dentists out there that feel the same way I do, that Medicaid is a great way to give back. There are other ways. Obviously, teledentistry has a place. I'd just like to allude to the question that was asked earlier about the 50-mile distance. Even if a teledentistry exam is done, which in my mind is nowhere comparable to an in-person exam, totally different things. The teledentistry exam is going to require some type of follow-up. Now, if you're talking to a dentist 300 miles away and you need a filling or an extraction, it's not going to do you any good to know that, yeah, you got a bad tooth. There's just nothing I can do about it. So that's set for a limit. I mean, a reason for that limit is you have to have access to the actual dentist, because as Dr. Schatz alluded to, this is a hands-on gig. I mean, everything we do is tactile. I can't fix a tooth through a screen, or can't pull a tooth through a screen. So I think that there are reasons for those types of things. I'll be happy to try to answer any questions from a rural dentist standpoint if you have any.
I see no questions. Thank you.
Thank
Dr.
you.
Mitchell. Up next, Jeffrey Schulitzer from Smile Direct Club.
Thank you, Chairman, members. My name is Jeffrey Schulitzer. I'm the Chief Clinical Officer of Smile Direct Club. I am a dentist, and with me is Ray Collis, our Director of Government Affairs. I want to be as brief as I can and to the point. I think we've heard a lot about access to care. We've heard a lot about dental deserts and all this concept. The issue I have with the bill, we oppose the bill, and the best way I can describe it is if we have this sheet of paper, the bill that's in front of you covers a small square of the available teledentistry that's out there today. Because in this bill, it limits the types of teledentistry that can be done. It limits locations of how it can be delivered. And it also limits the providers who are performing. Because, for instance, the crux of this is, in theory, dentists delegating services to other auxiliaries. But what about the dentist, him or herself, doing teledentistry directly to the patient? That's not in this little square. That's outside of it. And at this point, if this gets passed, it prohibits that. It has to fit within, according to this bill, to do teledentistry, it has to fit within this little box. So there's certain locations, certain requirements. You have to get a permit from the dental board. a piece that I'm not sure if I understand why you would need a permit to perform services you already perform under your dental license. Why do I need an additional permit? So that's an issue as well. Also, the concept of who can perform scans. Scans are 3D images. It's photography. It's fancy photography. And honestly, it's no more sophisticated than this phone. In fact, the phone is probably more sophisticated in some ways. And yet this bill allows for the patient to conduct their own photography and supply it to a dentist. But it doesn't allow a technician, not licensed, but a technician who's trained to do a scan. It just doesn't make any sense. And I need to call out that the scan does not involve any ionizing radiation. It's very simple photography. It's all it is. And also, currently, it's actually the crux of a litigation that's pending between Smile Direct Club, a corporation, and the dental board. So I was just kind of concerned about that. And then lastly, because I want to be brief, is, again, access to care. There are 20 counties in Georgia that are dental deserts. A 50-mile radius is not broad enough, and I don't understand the concept of it, because if I'm conducting teledentistry and that patient's 100 miles away from me, or 100 miles away from the supposed referring dentist or authorizing dentist based on these definitions, I can always find a dentist that will do what I need him or her to do for my patients, who are right there in the community, right next door to my patient, and make it convenient for them. And that could be an orthodontist, it could be a general dentist, it could be anybody. So I just want to express and make sure that we're concerned about the right things. Access to care, very good thing. Our model provides access to care, not only to these dental deserts, but counties that have urban environments where orthodontists don't go. And that's important because those people are forgotten. They're within a location where in theory there are orthodontists, but there aren't. And you might say, well, what's orthodontists? Who cares if we need to do orthodontics for our patients? The issue is that orthodontics actually is a gateway to oral health, which is now the segue into general health. So it's very important for esteem and all those sorts of things. And the last piece I do want to address is teledentistry exams are as efficacious or efficient, as safe as in-person exams. There are 20 years of data that actually indicates this and shows this. And not only that, but oftentimes a teledentistry exam is even better because you don't see the card the patient came in on. You're not looking at the clothes they're wearing. So you create a treatment plan that addresses the patient's true condition, oral condition, with no other subjective things around it, like the fancy cell phone they may have or a fancy car they drove in on. So I'll stop here. Any questions that you folks may have?
Thank you very much. Okay, up next, Ethan James.
Thank you, Mr. Chairman and members of the committee. I'm Ethan James. I represent the Georgia Dental Hygienists Association. And I do want to thank Representative Dempsey for bringing forth this legislation. I think this is an important topic. And I want to make clear that the Georgia Dental Hygienists Association does support teledentistry. However, we do have concerns with HB 441 as introduced. Joining me today is Kathy Starr, who's a member of the leadership for the Dental Hygienists Association. She's going to speak to some of the educational requirements for dental hygienists versus dental assistants. However, I do want to clarify a few points first. Representative Sharper, you did have a question about the coronal polishing. I believe it's called, the law now calls for rubber cup prophy, and it is available to be done by dental assistants only on patients with primary dentition, which means baby teeth, primary teeth. Section 2 of this legislation would change that for a dental assistant, and it would change it to coronal polishing. And on any patient, not just primary, not just baby teeth, we don't believe that Section 2 belongs in this bill whatsoever. It has nothing to do with teledentistry. It does represent a scope of practice change for dental assistants. And again, the Dental Hygienists Association does oppose specifically Section 2. Regarding the distance, the 50-mile distance, I should report that there are 136 counties out of 159 counties in Georgia that are dental healthcare deserts. 22 counties in Georgia have no dental provider whatsoever. So for the Georgians who live in those counties, a 50-mile radius is awfully tight. I do appreciate the fact that we're talking about patient safety. Again, the Dental Hygienists Association supports patient safety. We want that access to in-person care that is appropriate. I think the 50-mile limitation might be a little tight, especially for a lot of these rural communities. With that, I'm going to turn it over to
You have
to
a question
Kathy.
first.
Yeah.
Representative Sharper.
Yes,
Thank
sir.
you, Chairman. Because, you know, I'm all for teledentistry and it's about the patients. But like you're saying, when I had the question about the dental assistants, and then I go to line 227 as well. So basically, is a change here. But if they're already able to do certain things, why that's in the bill period, if it's nothing changing?
Well, it is changing in Section 2,
Right.
what a dental assistant does. And again, we think that represents an extreme scope of practice change for dental assistants, and we oppose that. But, you know, speaking of lines 27, 28, what you're doing is lumping under the term dental auxiliary. You're lumping together dental hygienists with their extraordinary education, experience, and training, and licensure and regulation, like Kathy's going to speak to, with dental assistants who do not have the same level of experience and education and training. And they're certainly not licensed professionals. So I think it's probably not accurate to put those together. And honestly, it's probably not appropriate to have dental assistants as part of this legislation whatsoever.
Right.
And with that, I'll turn it over to Kathy.
Okay, and also just mention, like when I see on 229 where it says dental assistants shall meet any education, training, or other requirements established by the board, basically regarding to what we're seeing for 227 all the way through 230, makes me feel and see that there's something different for a scope.
There certainly is and they have I believe it is Rule 150-9-.02 sets out the Board of Dentistry's requirements for dental assistants.
Okay. Well, I'll let her, present, and then we'll
Thanks,
see what
sir.
happens.
Thank you. Good afternoon. Thank you to Chairman Hawkins and the committee for allowing me to address you this afternoon. My name is Kathy Starr. I've been a registered dental hygienist for over 40 years, the last 25 years here in Georgia. I'm speaking today on behalf of the Georgia Dental Hygienists Association. And again, I thank you allowing me to address this committee. I also thank Chairman Dempsey for bringing this important subject to the table. GDA, the Georgia Dental Hygienists Association, supports the use of teledentistry. As you know, the governor authorized the use of teledentistry during the public health state of emergency. While we support teledentistry, we do have concerns with the bill as introduced. For the sake of time, I would like to focus on what we consider the inappropriate inclusion of dental assistants in this bill. There is a great difference in the education and training between dental assistants and registered dental hygienists, and I would like to talk to you about this for the qualifications for registered dental hygienist. A registered dental hygienist must be a graduate of an accredited program by the Commission of Dental Accreditation of the American Dental Association. This program must be at least 2 years in length, and we must sit for an 8-hour national board exam as well as a regional clinic patient-based exam in order to be licensed by the state. I know we have already shared with you a copy of our core curriculum with you on the information sheet. We are licensed and regulated by the Georgia Board of Dentistry with enforcement mechanisms. On the other hand, the expanded duty dental assistant does not have the same education as a dental hygienist, nor are they licensed and regulated. They must also work under direct supervision of the dentist. As mentioned earlier, House Bill 154, which you passed in 2017, allows for the general supervision of dental hygienists in Georgia. These services are fully within the scope, as currently written, for the dental hygienist. However, what this bill represents is an expansion of the scope of practice for dental assistants, and the Georgia Dental Hygienists Association does not feel that that's appropriate for patient safety. The Georgia Dental Hygienists Association respectfully asks that any references to dental assistants be removed from the language throughout this bill. Once again, I thank you for all you do for the citizens of Georgia and for the opportunity for allowing me to address you this afternoon. Thank you.
Representative Bentley.
Yes, sir. Thank you, Mr. Chairman. I guess this question is really for both of you. Thank you for your presentation. You mentioned, ma'am, the governor's state of health emergency.
Yes.
Was there a radius requirement, mile radius stated in that health emergency?
Not to my knowledge.
Not to my knowledge.
And again, I believe the practice of teledentistry during the public health state of emergency worked flawlessly. It was such an amazing tool, and we do support the use of teledentistry, and we want to see a good piece of legislation move forward. We just have concerns with some of the elements of 441.
And I'm just trying to get a better understanding of your statement about the 50-mile radius not really helping rural Georgia like it should be designed in this legislation. So I'm trying to get a better understanding of that. Has there been any discussion with the author of the bill about your concern of the 50-mile radius?
I was able to meet with Chairman Dempsey, and we had a great discussion. We pointed out some of our concerns. The legislation was drafted without the input of the dental hygienists. I think the Georgia Dental Association has been working on this for a number of years, but without our input, which is disappointing because I think we work together. Of course, dental hygienists work under a dentist, but as an important part of the care team, I wish that we had been at the table in the creation of the drafting of their legislation.
Okay.
Okay, thank you. Representative Dempsey, would you like to follow up, or the GDA? One, Teresa, either one. Thank you.
Thank you, Mr. Chairman.
Thank you. Thank you very much.
I'll start and then let Teresa say a little more, and in case you'll have questions, if I can ask to reserve some time at the very, very end. But I think that you're hearing also from the hygienists that they are, everyone's trying to get to the same place, to make sure that we're providing the best health care possible. The 50-mile and other things in this bill are very specifically tightly drawn for good reason, to make sure that the best care and the best emergency services are also allowed. I want to let Teresa explain a little bit, though, about that dentist and the way the dentist can authorize another dentist also to be close, so that expands it throughout the state.
So earlier, when you heard from our experts talking about a network of dentists, that would mean that if we have a dentist who is in Atlanta and we have a dentist who is in Monticello, they're able to send a hygienist or an assistant from the Atlanta practice to their area down south and have as a referred dentist. So if they saw a patient, they would be able to refer them for an emergency to that referred dentist that's 50 miles from where they're having a cleaning. So that is creating the network and having dentists work together, because we do have shortages of assistants and of hygienists. So that would help create that network right there. The 50-mile radius is for patient safety, but it also is a greater radius than what CMOs are currently allowed to do, which is 30 minutes or 30 miles or 45 minutes or 45 miles for one provider for dentist or a subspecialty dentist.
Okay, are there any questions? All right, hearing none. Do I hear a motion? Does anyone like to make a motion? Well, the chairman will. I move the bill. Do I hear a second? Representative Sharper.
Thank you, Chairman. I think the biggest thing we're seeing here, I mean, when we're looking at the dental hygienist, the dental assistant information throughout the bill, I mean, nobody really has a problem with the teledentistry. It's just that we're talking about the dental assistants throughout the bill of expanding duties, dental assistant. We're seeing so many things about dental assistant in which, I'm gonna just put it plain to you. It's like this. If we have a shortage on dental hygienists and you feel we need help, I know a lot of great dental assistants that can do a lot of stuff because they see it every day. But it doesn't necessarily mean it's in their scope, even though they know how to do it. And like I say, they're not regulated to do certain things. But if there's a dying need of, getting these patients taken care of, and we needed more, dental assistants be able to do more things, then you go to a more qualified program to make this happen, or some type of training. But to put it here, and there's really no regulations of it, and really what the scope really is, it really makes this bill more confusing because it is a scope issue.
So if I can just clarify, the only expansion of scope for a dental assistant is that currently in an office, a dental assistant under direct supervision can do a digital scan, which is a probe with a camera on the end of it, and take photos, not x-rays, photos within the mouth.
Okay.
This bill allows for an assistant to go out of the practice and to do a digital scan under general supervision, which would mean asynchronous in real-time communication with the dentist. So the dentist would still be monitoring via video. That is the only expansion for a dental assistant. And that in and of itself, just the dentist being able to look with a camera, not a perfect, definitely not better or even equal to what an in-person exam would be, but that exam alone would help a dentist say, you really do need to come in. It looks like I can see some abscess here. I can see that you need a filling, and they can actually go into a dental office. And that is the only expansion for a dental assistant.
Okay, and that's my point. There's an expansion, of the dental assistant practice that may go into another realm that needs to be taken care of. I think we need to figure out a way, because we want the patients, to have the care they need. But with the language and this whole deal about the dental assistants, we need to come up with a plan for them not to be able to go out of their scope or think harder on this bill. Because the way it is, I can't support it. Section 2 and anything with the dental assistants, because it's a scope change. So that's just where I am on it right now.
The scope change would not address what the law currently is, which is that a dental assistant cannot do a cleaning. They can't go in and use a tool and remove decay. They can't remove plaque. So that would still, they didn't go to hygiene school, just like a hygienist didn't go to dental school. So those licenses would remain the same, and that literally the only thing that changes is that versus doing it in person with direct supervision from the dentist, they're doing it under general supervision with the dentist watching via a video.
Okay.
So to clarify, all you're talking about is an assistant taking a rubber cup with some pumice and cleaning teeth?
That could also happen, yes, sir. But that's already allowed under the law.
Okay.
Any other questions?
I don't know if this helps, Representative Sharper, but right now the hygienists do not have a dentist in real time watching what they're doing. This also brings more, I would say, more real time to that conversation. When I first read it, one of the things I thought about was, so these assistants, they are watched in real time. It's not that it's a report back on, from notes or something. You're being observed. So that is the tele component of it, that there is more oversight actually than exists today. Also, I thought about the fact that when we did the original bill, and I think you were there in Representative Cooper's committee, we went through a lot of work to do that for the hygienists. I remember thinking how good that could also be for someone in a nursing facility or a safety net place, perhaps, that they wouldn't have to leave or be transported unless it was really necessary, that hygienist, that assistant would be able to look in there with the dentist's oversight and make a very important decision as to whether this is an emergency that we need to get someone more care rather than perhaps, the trouble of the inconvenience, the disruption of a patient, perhaps, that is in assisted living or a nursing home, going somewhere when they didn't really need it. So I saw it kind of from both sides of that. There is the prevention mode, but there's also, I think, a genuine level of different care for that patient.
Representative Sharper, you off? Okay, go ahead.
Thank you, Chairman. I'm just gonna say this. I'm just one person, right? That was just my concern of giving a little more time to see what we need to do as far as the scope situation, because what we're gonna have to look at the precedents that we're gonna set. That if we do this and let them do it, what other industries, what other professionals, professions are gonna say, we wanted them to do this. They can't normally do it, but we want them to do it because of telemedicine as a whole. So we have a lot more people coming in to do that, even on the pharmacy situation earlier. But we, verified that, okay, it's qualified pharmacy techs that be able to, to give the immunizations in certain situations, right? But just on this alone, I want my colleagues to be mindful that whatever we do with this, that we may see other professions that can't normally do something be able to open the scope up just a little bit. And then we're just going to have a lot of people open it up a little bit. But I trust, whatever my colleagues want to do, that's on them. But, I just want the best for the patient, but I don't want everybody in the world trying to open up their scope a little bit at a time for the sake of something. It's just the precedence, okay? All right, go ahead.
Representative Newton.
Thank you, Mr. Chairman. I do appreciate the dentist who came in and the idea of doing telemedicine or teledentistry in this case with a seriousness. I know I've been the recipient of a telemedicine visit with a doctor who was in Miami. There's not much you can do if they don't have a local connection if you did need a bigger problem. I appreciate and understand the 50-mile, or maybe it's 75 is where I'd go. But so I do appreciate the seriousness that I know I've done telemedicine visits in schools with a school nurse there on the other end, and the difference of just an iPad visit, like through my insurance plan, and a visit with a trained person at the other end, working synchronously with you at the same time. I really love that part of the bill. I would agree a little bit with Representative Sharper on why did the dental assistants used to be limited to primary dentition? Because that's current code as far as I understand. And I guess what's changed in their training, or is there something crucial in teledentistry to where doing this coronal polishing on not just primary teeth, but on everybody? Is there something about that is part and parcel of being able to do teledentistry? Is there some reason we used to limit it to primary teeth?
So it's obviously not a patient safety issue because we're allowing dental assistants to do this on children. And not adults, which is interesting. Their teeth will fall out. Yours will not with a rubber prophy. When that is, if you don't know what that is simply when the hygienist or dentist takes the polish and it kind of tickles your gums and maybe the roof of your mouth. That's all that is they're polishing your teeth at the end of the exam.
Okay, thank you. I tell you what, in the interest of time, I'm going to table this bill. Maybe you guys can get together and figure something out. But at this point, we're just going to table the bill. Thank you. Okay, does anyone ever want to make a motion to table? Okay. Thank you. Up next, HB 434, and I'm going to make this fairly quick. We have a few people to speak to it. Yeah.
Do pass, Mr. Chair.
No. This is a hearing only
Mr. Chair, I
on
think-
434.
Mr. Chair, this bill is so good. We need to
Thank you.
pass this.
Thank you. Let me briefly just speak to this bill. In today's healthcare world, we have radiologists, technicians. And the technicians have progressed over the years into a realm of more of it being an assistant. The radiologists are using these in certain procedures, and it's something that is something that's going to be moving forward in the future. This bill will need to go through GORC, which is the committee that reviews any licensing changes, and so that's the reason we're having a hearing only today. Is Becky Riles still here? Okay, Becky, if you get up and speak, and if you can do it sort of quickly, I'd appreciate it.
Absolutely.
Doc speak.
Absolutely, Mr. Chairman.
Thank you.
Thank you, Chairman Hawkins, members of the committee. We appreciate very much your hearing House Bill 434 today. I'm Becky Riles. I am representing the Management Services Network, which is the administrator for the Georgia Radiological Society. With me today is Dr. Joe Birch, a radiologist from Rome Radiology Group. Rome Radiology Group employs 4 radiologist assistants. And Mr. Chairman, you've actually explained the bill, so I'm going to turn it over to Dr. Birch so that you can hear firsthand how a radiologist assistant is a radiology extender so that the radiologist can do more interpretation of studies to get a diagnosis for you and patients in your districts in a much more efficient manner. So with that, I'll turn it over to Dr. Birch.
Good afternoon, Chairman Hawkins and members of the committee. I'm Joe Birch. I'm a radiologist in Rome, Georgia with Rome Radiology Group. I've been serving patients in Georgia for 32 years. Radiology assistants are a very important role in the diagnosis and treatment of patients in our healthcare system delivery. An RA serves as a physician extender for a radiologist, allowing us as the radiologists to spend more time interpreting studies to expedite the quality of care for patients served. The Georgia Radiology Society supports this legislation for the following reasons. Radiology groups in Georgia, like other medical specialties, are challenged with a workforce shortage. A radiology assistant helps the radiologist and makes us more efficient in providing care for our patients. RAs are valuable for radiology groups in both urban and rural areas of the state. House Bill 434 will provide a career path for technologists, radiological technologists, improving our workforce recruitment and retention for these individuals here in the state of Georgia. Radiologists are responsible for the direct supervision of the RA and the competency of the procedures performed. Licensure for radiology assistants under the Composite Medical Board seems appropriate, as they already provide oversight for me, my physician colleagues, and other physician extender healthcare providers. For these reasons, we ask you to support House Bill 434. Thank you for allowing me to speak today, and do you have questions?
Thank you for your presentation. So radiologist assistant is something that exists right now.
Yes.
This and it is advanced above a rad tech, or radiology
Yes.
technologist. So that you got to start with that, and this is something beyond.
Yes, it's basically a master's degree level of education. The closest school to us is University of North Carolina. We have hired 2 of our rad assistants from that school, and they're excellent. They're well trained. It's a 2-year program. After the 2 years, they have oral and written boards on a national level, and then they're certified to be an RA. we're asking that they be allowed a licensure so that we can certify them and allow them to, be essentially like a physician assistant is, or a nurse practitioner here in the state of Georgia. And over 30 states have either licensure or some sort of regulation for these for RAs.
Thank you, sir.
Before the chair leaves, I tell you, this bill is, I know the author of this bill, and I can tell Becky has done such great work on this bill. I move that we do pass it, take it from just hearing only, and do pass it out of the committee.
We need to wait the door, but thank you.
Thank you for that. Chairman says we'll entertain a motion later. Did you? Were there any others that wanted to speak to the bill? Thank you very much. Thank you for a
Thank y'all.
well-crafted piece
We
of
appreciate your
legislation.
help.
Thank you all. And